Good evening. It's now 6 o'clock and I'm handing over to Dr. Shadai Brett. Thank you.
Good evening, junior doctors, JUDASA members, and supporters from all across South Africa. My name is Shadai Brett. I'm the Vice President of the Junior Doctors Association of South Africa, and I'm also a community service doctor, currently completing my year in the Western Cape. Welcome to all of you. Thank you for taking the time to be with us this evening to talk about this important topic. As many of you know, September is Suicide Prevention Month. And so JUDASA is taking this opportunity to show you that we are prioritizing the mental health of our junior doctors and our members. And so we are now going to be having a talk entitled When the Healer Hurts, addressing the mental health epidemic in junior doctors in South Africa. And who better to be speaking to us about this topic than Professor Hoare? Professor Hoare is a neuropsychiatrist, professor at the University of Cape Town, head of the Division of Consultant Liaison Psychiatry UCT, and co-director of the UCT HIV Mental Health Unit, as well as a senior consultant psychiatrist at JUDASA Hospital in Cape Town. She is the chair of the Brain and Mental Health Scientific Committee for the National Institute of Health USA, NIH-funded International Maternal Pediatric Adolescent AIDS Clinical Trials, or IMPACT, network, which is a global collaboration of investigators, institutions, community representatives, and other partners organized for the purpose of evaluating prevention and treatment interventions for HIV and HIV-associated complications and comorbidities in infants, children, and adolescents, and during pregnancy and postpartum through the conduct of high-quality clinical trials. She has been the principal investigator or co-investigator of a number of NIH USA federal funded research projects in South Africa, which focus on mental health, neurocognitive disorders, neuroimaging, epigenetics, and developing adherence interventions in adolescents living with HIV. In 2021, she became the first neuropsychiatrist to be registered with the General Medical Council, GMC, in the UK. Her clinical work includes treating mental illnesses, neurocognitive disorders, and adherence in adolescents and adults with chronic illnesses. She has significant clinical experience in managing the mental health consequences of COVID-19 and supporting healthcare workers. Her interventions for supporting clinicians have been published in international peer-reviewed journals. She also founded and chairs the Better Together Adolescent Service at JUDASA Hospital. Thank you, Prof. Hoare, for taking the time to be with us today and to address this important topic. Over to you.
Thank you so much, Sade, and thank you very much for hosting me this evening. Protecting the mental health and thinking about the mental health of healthcare workers and clinicians is becoming an increasingly important and part of what I do. I feel passionately about looking after and protecting my colleagues. And I hope that what I share with you this evening will be helpful to those of you out there who are working in institutions that I don't have any contact with. But I certainly hope I would certainly be very happy to continue the conversations with you all and to be available for any questions related to the talk after this evening. Next slide, please. The prevalence of depression, anxiety, insomnia, and PTSD in doctors following the COVID-19 pandemic has unfortunately been high. A systematic review of healthcare workers' distress following all infectious disease outbreaks has identified that our distress may unfortunately also continue for years. Work-related psychological distress in doctors may be associated with multiple adverse outcomes, such as long-term cognitive impairment, substance use, suicide, poorer physical health, as well as impacting patient care and conflict with colleagues, and also leaving the healthcare profession. In the run-up to the COVID-19 pandemic, there was recognition that clinicians were already overstretched, under-resourced, as well as being chronically distressed. The COVID-19 pandemic has highlighted the need to reassess and reconstruct the culture of our healthcare institutions if we are to ensure the long-term well-being of doctors. Unlike sports teams, there is no reserve team of doctors waiting on the sidelines to substitute those on duty so that we can rest. We need to be bold and start a revolution to change medical culture. I'm asking you tonight to be courageous and to join me in starting a revolution. According to the Medical Protection Society survey released at the end of last year, more than a third of doctors in South Africa say their mental well-being is worse now than it was during the COVID-19 pandemic. And 39% of those surveyed say that the impact of burnout and exhaustion is impacting their ability to care for patients safely, as well as impacting their mental well-being. A quarter of the participants are considering leaving the medical profession or retiring early to mental well-being concerns. Additional studies have indicated that over 70% of young doctors working in primary care in South Africa are from the cumulative effects of mental and emotional stress, high workload, and substandard facilities, and job instability, distressed, and depressed. Next slide, please. We work in a society that is characterized by poverty, deep inequality, and violence. The environment in which healthcare work is performed is deeply distressing in itself. And this compounds the experience of moral distress in healthcare, as resource shortages in the system, combined with patients' very difficult personal circumstances, leads to frequent exposure to distressing ethical situations. Moral distress is increasingly, albeit slowly, being recognized as the primary occupational hazard for clinicians working in South Africa. Studies have found a causal relationship between moral distress and job performance, burnout, and most concerningly, patient care. Doctors experiencing either moral distress or moral injury are at higher risk of developing chronic physical and emotional exhaustion. Work-related psychological distress in doctors may be associated with burnout, depression, PTSD, and long-term negative adverse effects, such as decreased quality of patient care, conflict with colleagues, cognitive impairment, substance use, suicide, poor physical health. Next slide, please. The traditional medical workplace, where a rigid hierarchy model of leadership has dominated, is now outdated. Power concentrated in the hands of few can be wielded indiscriminately against junior doctors, creating an environment that compromises psychological safety and destroys the open and collaborative culture that produces good clinical care for our patients. Next slide, please. The culture of medicine frequently reinforces that self-care is selfish and that physical and emotional exhaustion are to be expected. In addition, the belief that vulnerability is a sign of weakness in medical culture is reinforced regularly. Despite the importance of psychological safety in healthcare teams, it is often lacking. When teams are psychologically safe, they have a shared belief that they can take interpersonal risks together, such as speaking up, asking questions, and sharing ideas about improving the situation in their hospitals. A lack of psychological safety drives talented individuals out of medicine. Loneliness is a subjective feeling of disconnection. Next slide, please. We can feel alone in our hospitals despite being surrounded by multiple other healthcare workers, including other doctors. Loneliness independently contributes to the risks of poor health, including substantial increases in the risk of many medical issues and strong evidence demonstrating increased risks of cardiovascular disease and death from any cause. Many studies have shown that those experiencing loneliness have an increased risk of anxiety and depression, dementia, infectious diseases, poor functioning, and death from overdose or suicide. Problems arise within healthcare facilities, in our hospitals, when feelings of loneliness or being disconnected from our colleagues becomes chronic. A high rate of loneliness in medical settings has been correlated with poor work organization, less managerial support, worse atmosphere in the team, and more irresponsible attitudes of our colleagues. Loneliness in clinicians can also be used to predict occupational burnout. Historically, clinician well-being efforts have overemphasized individualized resilience programs, thereby placing the burden of managing work and patient care-related emotional distress on the individual clinicians themselves. This, however, discounts the role of the environment in which we work. We already are resilient. We have come this far. Programs relying on individual clinician referrals often fail because they require clinicians to recognize and name that they are struggling and name that they are needing support. Stigma, shame, and isolation are substantial barriers to the success of these individual-focused well-being efforts. We tend to feel isolated and lonely in our vulnerability and suffering. This belief is reinforced by a culture of silence in our hospitals, which convinces each of us that everybody else, that all our other colleagues are successfully managing these stresses. Studies have shown that many doctors struggle to tell their colleagues or their employer about their mental health problems. The most commonly cited reasons are perceived stigma and anticipated damage to future career. Suicidal ideation in doctors can present strong fears of stigmatization. Next slide, please. I think we are at risk of misunderstanding the challenge if we think that the awareness and need of support, connection, and belonging in our hospitals should return to the way they were before COVID-19, which I believe they already have. I would argue that the goal is not only recovery from the ravages of the waves of COVID, but also learning lessons for new ways of working together. A positive working culture in our hospitals is diverse, collaborative, transparent, where your contributions feel supported, where you feel seen, and where you feel valued. I have learned at JUDASA that good teamwork and walking alongside my colleagues, including those junior to me, is welcomed by everybody. We have and should continue to take time to listen to and care for each other. Attention should be sustained regarding maintaining the healthy coherence of the teams in the face of ongoing pressures, particularly now as we exit one crisis, COVID-19, and roll into another, that of the budget cuts. Mental health professionals are already convinced of the therapeutic value of being able to tell one's story, especially to those who have had similar experiences. This type of social support in healthcare settings can help reduce feelings of isolation, which compound loneliness and trauma. Sorry, I need to ask folks to keep quiet in the Bye. Sorry. Kids leaving, dogs coming. I often reflect on the nature, structure, and function of human connections in my hospital, a function that I have found to be indispensable to my own mental health. Being connected to others around us is considered a fundamental human need, crucial to health and wellness. So, if I had to ask all of you who are listening, instead of who is tired or who is stressed, who of you are lonely? How many of you would raise your hands? Loneliness and a lack of belonging in our hospitals is such a hard thing for us to admit to. It's uncomfortable, and we tend to want to turn away from uncomfortable topics. Discomfort makes us want to move on to a different topic. In actual fact, it takes courage for me to ask you the question, are you lonely? Because I need to be prepared to hold the space for your answers. Willingness to ask uncomfortable questions opens the door to great conversations. This is how we build relationships, how we reach out to others who are in trouble and feeling lonely, and how we create a community of inclusion. The key lesson learned from our time spent working on the COVID-19 frontline was the power of a connected clinical team. That sense of being connected to each other and to the experience around us, the sense of belonging, the sense of safety created by the teams, a connected team, is something that we should be holding on to. Next slide, please. Changing the public healthcare system is complicated, and it is outside of the scope of doctors who simply turn up for work every day. We cannot control the number of patients who arrive at our doors daily or change the economic and social settings of our hospitals. However, setting up a system where clinicians can contribute to a change in medical culture by changing how we relate to each other, how we talk to each other, and how we talk to each other and share experiences, share work-related stress, and create psychologically safe teams. This can strengthen each and every one of us and should be part of the solution. Previous research has established the benefits of improving psychological safety in healthcare teams. And it is about time that we build interventions that do so. All clinicians, all doctors, regardless of your level of seniority, should be calling, in fact, demanding time for peer support groups to be integrated into your working week. It is clear that when necessary, we were able to liberate clinicians to enable them to attend group sessions. We did this throughout COVID, despite our limited resource setting, and this should continue. Next slide, please. During and after the COVID-19 pandemic, I've been running weekly support groups in a variety of departments in my hospital. The advantages of running groups in medical institutions is that they decrease burnout, increase empathy for each other, help with the management of stress and anxiety, and create more positive attitudes about our colleagues. The sessions facilitated really tough, really difficult conversations, during which clinicians could openly discuss their feelings of frustration. The conversation topics were determined by the group members, while my role was to facilitate the discussions only. I also believe that what was most helpful was that I did not try to fix anything or tell colleagues what to do. Sorry, folks, just give me a minute to move to a quieter area of the house. So the conversation topics that we covered were determined by the group members, not by me. My role was to facilitate the discussions only. I also believe that what was most helpful is that I did not try to fix anything, and I did not try to tell colleagues what to do. Next slide, please. In societies characterized by deep inequality and violence, such as ours in South Africa, the environment in which we work is distressing in itself. This environment compounds the experience of moral distress in our healthcare systems, as resource shortages also lead to frequent exposure to having to make very distressing ethical decisions. It is important in these group sessions to facilitate a space to think through these really complex ethical and moral dilemmas, those issues at risk of causing moral injury, a stressor that doctors are particularly vulnerable to. Providing protected time to reflect on the personhood of patients, our relationships with each other and our relationships with patients, and challenges in the hospital, including our emotions, our emotional responses to situations in the hospital and to patient care. Talking about our self-care during these group sessions was restorative for our clinicians. Next slide, please. By revealing a more vulnerable and honest version of ourselves, the colleagues around me could feel more able to share the difficulties of working in healthcare that up until now they have chosen to conceal. My experience is that doctors want to disclose and receive support from other doctors and colleagues rather than mental health professionals. The groups were accessed by a range of clinicians across the traditional medical hierarchy and were well attended. The sessions often extended beyond the appointed end as people stayed milling around wanting to talk. I was given so much positive feedback regularly, saying how helpful it was just to talk about what was happening to them. However, it is important to acknowledge that the stresses that we are frequently under in a limited resource setting made protecting everyone from all negative health outcomes impossible, despite our best efforts. There are circumstances in healthcare that will overwhelm all, despite us being resilient and despite us being able to access good psychological support. Next slide, please. Emotional stresses in the medical field are occupational hazards, not mental health problems. I'm going to say this again. Emotional stresses in the medical field are occupational hazards, not mental health problems. Programs relying on individualized mental health interventions alone, without including peer support, are frequently not used by the clinicians who need them. Clinicians are more likely to accept support from colleagues who understand their specific environmental stresses. The collegial support team building model also reduces the stigma associated with receiving support as it normalizes receiving support. Seeing that your colleagues around you understand your emotional responses and that they've had similar experiences to you reduces those feelings of loneliness and isolation and shame associated with feeling distressed working in healthcare. The peer support sessions did and have not replaced individualized mental health care when it is needed or requested. In fact, the support sessions and easy access to myself, the psychiatrist working within the medical teams, facilitated onwards referral to other mental health professionals. Also working alongside a psychiatrist in the medical team and wards has played a role in normalizing mental health care. Next slide, please. I believe that social connections, friendships, and feeling a sense of belonging in the workplace is protective of our mental health. There are two key elements that are required for social connections to happen organically and for them to be maintained. First is continuous unplanned interaction, and second, shared vulnerability. In the hospital, we are in a lot of environments that allow for continuous unplanned interaction. However, these corridor conversations, for example, are not sufficient to create a sense of connection and belonging. In addition, we need to create protected time for teams to have the opportunity to share vulnerability. Clinical teams need to engage in the active process of teaming, which occurs when diverse clinicians are brought together for regular face-to-face contact, which stabilizes team membership and facilitates psychological safety. Teaming allows clinical units to adapt better to chaotic environments and to the demands of increasingly complex patient care. There are additional benefits to a psychologically safe environment within healthcare institutions, including improvement in well-being and a reduction in our burnout. Next slide, please. Vulnerability is an important component of teaming and is the emotion we experience during times of uncertainty, risk, and emotional exposure. Translated into the clinical context, vulnerability is the doctor's perception and exposure of emotions essential to connecting with colleagues, understanding patients and their problems, and to recognize the distinctive relational character of practicing medicine. Importantly, vulnerability is not oversharing. It does not require us to reveal all the difficulties in our personal lives to our colleagues. Vulnerability is being okay with showing colleagues that you don't know everything. It is modeling striving to do what is right in the clinical setting over being right. It is having the courage to have tough conversations and to have difficult questions, knowing that you're going to have to hold the space for those answers. It is showing tenderness and choosing humanness over the archetypal doctor stereotype. It is asking a colleague, "Are you okay?" when you can see that they're not. It is having the courage to listen to and not give advice, and to be a steward of our colleagues' stories. It is the courage to get to know and see and care for the people that you work with. It is showing up and being seen, bringing your real self, not the self molded by generations of medical hierarchy and culture. It is about letting our colleagues who are in a position of perceived less power than ourselves see our emotions, see our tenderness, see our worry, see our not knowing what to do, but then see how we manage those feelings and those difficult situations when we aren't sure what the answers are. It is embracing being more fully attuned to the patient, to our patients, whose suffering and isolation demands that we open the heart of our professional being. Being vulnerable with each other in the hospital setting is an absolute requirement for real connection with our colleagues. Next slide, please. Connection is in our neurobiology, and why our experiences of disconnection can lead to feelings of loneliness, distress, and powerlessness. But connection is a schism, being a risk that we can engage in, but also the most caring and most important behavior that we can engage in. It is both frightening and wonderful at the same time. We want to feel a part of the hospital in which we work, to experience real connections with our colleagues. Authentic connections to our colleagues gives us more freedom to express our individuality without fear of jeopardizing our sense of belonging. Next slide. Belonging is a practice that requires us to be vulnerable and connected, to get uncomfortable, and to learn how to be present with our colleagues without sacrificing who we are in the context of the medical culture within which we work. Belonging is a feeling of psychological safety, of feeling accepted, included, respected, and feeling that you are contributing to your team. Psychological safety is associated with improved team learning and performance, making psychological safety in our hospitals particularly important as we provide safe care for our patients. Next slide, please. What sustained me and what I will hold on to as a result of that extraordinary time during COVID are the colleagues who survived it with me. We looked out for each other and we faced that catastrophe together. The connection and sense of belonging within our team provided the strongest protection against our despair and the strongest antidote to the frontline experience. I believe that my work with my colleagues has been helpful, but the experience has given me a window into the longer-term questions of the well-being of doctors in our under-resourced healthcare system in a violent and unequal country. We deal with and embody the consequences of a society that is not healthy. It is well established that doctors migrate from South Africa to wealthier countries for a range of reasons, including our unwell and stressed healthcare system. Next slide, please. Going forward, each of us, regardless of seniority needs to take responsibility for a change in medical culture. We should create time for attending weekly support sessions where we can, as teams, explore parts of ourselves together, think together, connect together within each unit or division. So ask yourself, where do you belong? Do you feel a sense of belonging in your department, in your division, in your hospital? Ask yourself, who are you nurturing? But not only that, who is nurturing you? Each of us must take responsibility to create these spaces, to facilitate this bidirectional nurturing and sharing of vulnerabilities, sharing parts of each other, which drives a sense of belonging. Next slide, please. Thanks, everybody, for listening.
Thank you so much, Prafua, for your inspirational talk. I think everyone here does want to join the revolution that you mentioned at the start of your talk. We want to see mental health among all doctors, but especially junior doctors, improve and get to a place where we feel like we can function in our daily lives. I specifically wanted to also thank you that you reminded us that we are resilient to start off with. Even the most junior of doctors have gone through a really difficult 6 years of med school and have made it through challenging circumstances to get there. And so much more if you've finished your internship and your community service and beyond. Thank you that you reminded us we're not weak and we don't all need extra training because we seem to have emotional responses and human responses to really traumatic daily experiences. So now I would like to open up to our participants and to our webinar attendees to ask questions to Prafua. Please send your questions on the Q&A function. And while you are all sending that, I think I'm going to just kick us off with the first question. So, Prof, in terms of trying to change a culture, that's obviously really difficult. We all know that people don't like change. And if I think from a junior doctor perspective, if you coming in as that intern and you in your first rotation or your second rotation, I mean, you've been probably taken away from a province or a support system that you were really comfortable in, and now you are just surviving day by day. How do you, as the bottom of the food chain, who's constantly struggling with imposter syndrome and trying to get your skills on par, and you trying to see your patients quicker, and you are trying to just stay awake for the call because you're not call fit, how do you go about taking on something as big as a culture that already exists in a hospital that was there long before you and will be there long after you're gone in 2 years' time? How can you practically address that? And is it something that we should look at on a big scale, or is it more like, what can I do for myself and how can I respond in certain situations?
I think what I have been observing over the years is that there is something that happens to us, and it starts in medical school, where our ability to be open, honest, empathic, and kind to each other, and open to sharing our difficulties, including emotional distress, is eroded over time. And I believe that is done because we observe, because we are taught to do so and be so by the people who teach us, and we observe that this is what's happening in hospitals. But each of us has a choice. You can choose to be that way, or you can choose to remain authentic to yourself, a kind, empathic individual who cares for your patients and who cares for your colleagues. I believe absolutely that we are strong, that we are resilient. Your interns, your junior doctors, your cosmos, you are exceptionally resilient and exceptionally strong. What happens to us isn't about us, it's about the system in which we work. And I can see what erodes our mental health. It is not the patients, it is how we are to each other and how our managers are to us. The patients don't cause me to feel the sense of, I am eroding. What am I becoming? I feel joy when I care for patients, even though I probably can't provide the care that I would like to be providing. But they themselves, there's a great joy that you feel when you connect with another individual, with a patient. Yes, patients can be unkind and they can be snappy, but the most significant unkindness, an erosion of myself that I've experienced, is at the hands of colleagues, particularly those senior to me. You always have a choice. Always. Are you going to be like that or not? I've spent a long time in my hospital wondering if who I am, my way of being, which is, I believe that I am a powerful woman, a strong woman, but I'm a deeply emotional woman. And it doesn't mean I'm silly or frivolous or cry all the time. It means I experience powerful emotions and I show them. And I can tell you that I am accepted in my hospital. I'm loved in my hospital. And people come to me for advice about goodness knows all kinds of things in my hospital. Not because I'm a hard person, not because I'm powerful, because I've published papers, but because I'm kind, I'm accepting, and I listen. We can all be this way. This is not some special thing that I've been born with. It's something that I've chosen to be. You can make the choice.
Yeah. I'm going to go over to some of the Q&A questions, and I'm sure we will circle back to a lot that Prof has said. This question is from Monica. Monica is asking, as a junior doctor who is not listened to by seniors, how can we encourage our teams to be vulnerable with each other? It is not a culture that is currently accepted. So how can we change that?
First of all, I want to say that that is wrong. You should be listened to by your seniors. I want to hear the voice of my interns. I want to understand how they're experiencing a patient, how they're experiencing a hospital. And regardless of what yes, I'm a senior individual, but I don't know everything. And there are things that my interns will know better than I will know. And I think what's an important part of being a really good leader in medicine is to be cool with that. I don't know everything. I can turn to an intern and ask them for help with, because I don't know this, or you guys have studied this a lot, kind of more recently than me. Do you know the answer to this? Because I don't know the answer to this. It is wrong to not listen to juniors. Completely incorrect. And that's how we maintain this terrible hierarchical culture. You might not be able to change a person who is rigid in their hierarchical ways, but you can choose to never be that way. You can choose to continue to be kind, continue to be open, and be vulnerable with your peers. Culture change takes time, but I promise you it is possible. But only if each and every one of us hold on to that we must be good and kind to each other. We must be courageous enough to help each other when we're in trouble. We must look after each other. This is a harsh environment. We only have each other when we're at the hospital, and we need to give to each other. We need to look after each other.
Thank you for that answer, Prof. I have another question of my own, and Prof, having worked in COVID-19 in the front line with the healthcare workers during that time, obviously you more than anyone knows how difficult that was on the mental health of doctors. If we're thinking now specifically of our interns and our ComServes and our junior doctors, I mean, we really caught the tail end of the COVID-19 pandemic. Personally, as a ComServe, I think I had about 3-4 months at the end of the COVID-19 pandemic that I was actually working as an intern. And so the interns who are currently in their first or second year, I mean, we've all come after the large waves, and yet somehow the mental health among junior doctors seem to be worse off and getting worse than they used to be years ago. And I mean, maybe this is due to more awareness that we're actually picking it up, or there could be many other factors. But why do you think this is? Why are there more suicides among junior doctors? I'm sure there's many people in the audience who have similar stories, but I know 4 people, not necessarily close friends, but colleagues and people that I knew personally that have committed suicide in the last year, and they were all interns or newly started ComServe. That's not something I heard of as a student. And people seem to think that is a large number when I tell them these things. So what are the factors contributing to this, and how can we mitigate that? How can we address that going forward?
Well, first of all, we all lived through the pandemic, whether you worked on the front line or not. And really, it's not just healthcare professionals that where we see an increase in the numbers of individuals presenting with depression, anxiety, and suicide. The whole world is like this. So I think in some ways we're just a reflection of what's happening globally, what's happening internationally. In addition to that, the people who you work with have suffered, and I believe their mental health has been eroded, their patience is eroded, they are burnt out, and less likely, I think, to be able to hold more junior people who are coming through the system. There are many, many of us that haven't recovered. That certainly, I mean, when we are unwell, it's very difficult to look after juniors. It's hard to look after others and be kind to others when you're yourself are unwell. And I think especially now, we really have, there's a real sense of betrayal. We were so committed to our patients during COVID and sacrificed so much. I have colleagues that moved out because their husband has a chronic illness and she went to go and live in an Airbnb and didn't see her family for ages. I had moms being separated from kids. We did crazy things to save, just to save our patients, isolating ourselves, putting ourselves at risk every day. And there are consequences to that. We're not all well anymore. And then find ourselves in another crisis, again, not of our making. And this time around, it feels worse, doesn't it? I mean, in some ways, there was this, during COVID, it felt like the whole world was fighting this enemy together. We were all together fighting this terrible thing. Now we're fighting each other for resources, for money, for staff. And in addition to that, our patients aren't fighting with us in this new crisis. They're often fighting against us because we're the ones responsible for saying to them, well, actually, I can't admit you, or I can't, sorry, we can't do that surgery anymore. And so I think we are being exposed. You guys are being exposed to significant stresses. And in addition to that, you don't have job security anymore. I mean, what guarantee do you guys have that you're going to have get an MO post, or get a reg post, or be able to specialize at all in South Africa? And that will be in the back of your minds all the time. So I don't believe we've emerged from COVID into an okay world. You have not come into an okay world. And we've gone from one crisis to another crisis, and you guys are in this crisis, being led by individuals who are still struggling to get over a crisis that we went through in 2020, 21, and 2022.
Absolutely. There's a question from Sazi. Sazi is asking, Prof, are there any debriefing tools that junior doctors can either use with each other or perhaps propose to be used in their facilities to help start the positive behavior of frequently reflecting on their experiences?
I said a couple of times during the talk, and I'm going to say, and I'll say it now again, you should be getting together every week with your colleagues. I mean, obviously different hospitals have different structures. So it might be that, for example, I meet with all the ICU staff every week where I provide a space for them to debrief, but it might be different. It might be that you work in small hospitals, and what you should be doing is that all interns and ComServes get together. It's nice to have somebody to be able to facilitate that, but if you don't, just get together and talk. Food helps often. We take turns every week. We take turns in providing food for everybody, and nobody comes with a plan of what to talk. But I promise you, there's like talking nonstop for an hour. And I think the most important thing is don't try and provide solutions to your colleagues. Give them space to talk and listen and be empathic about their experiences. And it's an exceptionally connecting experience. Listening to each other's distress, allowing each other to express your emotions every week, and it normalizes being open, being vulnerable, being kind with each other, and you get to know each other better. And that's also incredibly important. If I know you better, I know if you're not doing well much faster than if I don't know you. It also makes it easier for me to reach out to you if I know that you like me, that we've been kind to each other if I'm struggling and I'm in trouble.
And of course, ideally, that would take place within peers and colleagues at the on-person physical facility. I mean, that is the people undergoing all the trauma bonding with you. But since we have got this platform of JUDASA, Prof, do you think there is value in JUDASA organizing support groups, even if they're online and they're not necessarily with people that you see on a day-to-day basis, but just to connect people in a way that perhaps they don't have the opportunities to do at their facilities?
The most important thing that you can do to create psychological safety is face-to-face. There's no replacement for that. So I will get to your question around having online groups, but there is no replacement, because you can feel each other. I can feel if you're angry if I'm in a room with you, because there is more to read from an individual than your facial expression. So I can say these things when I'm face to face with you because I can feel the emotions in the room. I can feel I'm safe to say these things. That doesn't happen online. It's really tough to do that online, to feel that kind of sense of psychological safety. And with the regarding like a sense of tools for debriefing, I wouldn't even go with tools. Just be real and just talk to each other. And I mean, that was what the previous question was about, like a sense of tools for debriefing. The tool is make the connections with weekly groups, normalize talking to each other, insist with your managers, whether it's your consultant or the hospital manager, that you guys get together wherever you are every week and have this opportunity to debrief. It's just talking. Just normalize talking to each other. You don't have to use any CBT skills or whatever it is. Doesn't matter. That stuff doesn't matter. Just talking and being honest and authentic. And it's difficult in the beginning. When you get to know each other better, the more vulnerable you can be, the more honest you can be about the distress you felt with seeing a patient, etc., etc. I did run online support groups as well during COVID for other for colleagues, especially in the beginning, in the first wave, it was really tough. I'd say it was really hard. It's exceptionally hard to provide support, especially in a group setting with most people having their cameras off. It's tough. So I think it takes an incredible amount of skill to be able to support somebody to be able to support you all like this. I mean, even now, my experience of this is, if I had to give this talk in person, it's a lot more positive experience for me. I can see how you are all reacting to it right now. I have no idea whether you guys liked it or you didn't like it, whether you thought it was a whole pile of junk or whether you thought it made any sense to you. So that, in some ways, it's incredibly tough. I feel like I need to be really vulnerable to be able to give a talk in a setting like this about emotional content. I can give a talk about what HIV does in the brain in a context like this and feel totally fine about it, right? Because it's just information. I'm not giving you information. I'm giving you an authentic version of myself, of who I am as a person in this talk. And I have absolutely no idea what you guys think about it. I'm not seeing any nodding heads. I'm not seeing any smiles. I'm not seeing anybody going like, oh yeah, totally, thumbs up, or whatever it is. So it's very hard to do this. I mean, what I think is incredibly important is for JUDASA to create some kind of network of psychologists and psychiatrists who are responsive to individuals who are in trouble. What I find incredibly difficult is when my office is like a railway station of interns, comserves, heads of departments, like you name it, coming to my office saying, I'm struggling, there's a problem here. And actually the hardest thing for me to do is I usually problem solve first with whoever comes through my door. We're like, all right, let's try and figure out what the problem is so we can make a plan. And that's what I do. I make plans with people who are in trouble. And then, but often the solution to that is I've got to find people in private to help this person who's just walked through my door. And that's really tough. The hardest part is to find the psychologist, to find the psychiatrist. What I have seen some colleagues do is create, it's called a balance style group. So you might get together, perhaps, so instead of having sort of like individual therapy, so let's say there's a group of you working in a hospital, there are 6 or 7 comserves. What you could do is ask for a psychologist to do an online session with 7 of you, cameras all on all the time, and you have a group therapy session together about the stresses that you're having at work. So that's another option. Otherwise, find a local person. And again, that's cheaper because the psychologist, instead of paying your sort of 900 Rand for your 1 hour session, so there's 7 of you getting sort of some kind of therapeutic space for the same amount of money. And so that can be really helpful. In terms of providing a supportive space to a platform of 60 people, I see there's 60 people there online at the moment. Yeah, I would say that there are definitely limitations to that, but perhaps just something like this again, just sort of informative about talking about mental health of doctors would be helpful. I don't think what I did today is necessarily therapeutic. I hope it's thought-provoking. And I think a space like this can be thought-provoking. I don't necessarily think it can be therapeutic.
All right, I'm going to go on to the final question. This is from Mark, and Mark is asking, do you think one-on-one connections with a senior colleague, inverted commas, mentor would help? This is something that SAMA might be able to facilitate, and those connections might be something that they could help establish.
Thanks for that, Mark. So it's the internet. We don't have a lot of local data on what really matters to keep the mental health of the people that work with us, junior people that work with us. great, but the international literature shows over and over and over again, connection with your supervisor is the most protective of your mental health. That's it. Again, we don't have the data from South Africa, but I can certainly say that in my experience here, absolutely. So if you have a good connection with the person, your consultant, your head of division, you're far less likely to develop mental health issues than if you have if you don't feel safe in the division that you work in. So I think yes, it's incredibly important. A strong psychologically safe connection with a mentor is an absolute must for protecting junior doctors' mental health.
Thank you so much, Prof. Once again, on behalf of the committee and all of the JUDASA members, we appreciate your words of wisdom and the time that you've taken to talk to us today. We do also hope to continue this conversation in the future as we strive towards this common goal. I would also like to advise JUDASA members that we do have a new partnership with Whisper. This is a program run by ProfMed, and they offer emotional and psychological support after violent or even abusive events. They are giving this to SAMA and JUDASA members also at a discounted rate. And so they provide a 24-hour hotline, telephonic advice and counseling, as well as face-to-face counseling and legal assistance. As we were reminded today, there's nothing that can replace that face-to-face contact. If you do need support or assistance in any way, please don't feel hesitant. Reach out to us as JUDASA or to SAMA, and we will support you as much as we can. Thank you again to Prof. Hoare. This will conclude our webinar. I hope you all have a lovely evening.